Hello everyone. Now the topic for today will be the components of removable partial dentures. That is, to make a partial denture or to create a removable partial denture, or say cast partial dentures. Why is the name cast partial denture? It is because we are casting the partial denture with the help of metal ingots. So that is also called as cast partial denture. So removable partial denture or cast partial denture have got certain components by which it will be surrounded by and made of. Now we need to know for which case which all components are suitable and indicated, and for which case where are we supposed to give those components and for what condition of the patient. So let's see what are the different components of removable partial denture. Starting with major and minor connectors. We have direct retainers, we have rest seats, we do have indirect retainers, we have denture bases and the acrylic teeth or the artificial teeth that is going to come overall to solve the purpose of a removable partial denture. So to start with, let's start with the major connector. So as the name is suggesting to us, what exactly is a major connector means? It's that component of removable partial denture which connects one part of the prosthesis to the other part of the prosthesis from one side of the mouth to the other side of the mouth. Now this major connector is also responsible to connect the other sections or components of removable partial denture. For example, the major connector is going to get connected to minor connector. It is going to get connected to the rest seats. The rest basically, not the rest seat. But yes, it is also going to get connected to the indirect retainer, the direct retainers. So major connector, as the name is saying, is a major component of removable partial denture. As the definition says, it is that component or parts of the prosthesis located on one side of the arch which connects with the other side of the arch. So to continue with major connectors, let's see what are the requirements of a major connector. The basic requirement is that it should be rigid. It should provide a vertical support and protect the soft tissues beneath it. It should also have a means of obtaining the indirect retention wherever it is needed, because that is the part which is going to get connected to direct retainer. So indirect retention is nothing but we are providing a different rest to one particular area. So hence, this major connector should be connected to that particular area. It should provide an opportunity of positioning the denture base wherever there is a need, and it should of course be comfortable to the patient. So this is a major connector. We can see the part which is on the palate, that is a major connector. This is a major connector of the lowers which has been seen, the mandibular section. Now we need to see what are the different types of maxillary major connector. Let's start with the maxillary major connector. So there are different types like single posterior palatal bar, we have palatal strap, we have anterior posterior double palatal bar, we have horseshoe or a U-shaped connector, we have a closed horseshoe shaped connector, or a complete palatal coverage. The picture that we had seen earlier right now was an example of complete coverage. Now one more thing which is important here is a major connector should be how much distance away from the free gingival margin. Should be around 6 to 8 mm away from a free gingival margin. Now coming to the first one, that is single posterior palatal bar. Now what happens with single posterior palatal bar? You can see this is a half round in its cross section, and the bar is gently curved and should not have any sharp angle at the juncture with the denture bases. That is the most important thing. Second important thing with this kind of major connector is the L-beam effect. Now what is the L-beam effect? Now L-beam effect is one which the engineers use to make our roofs as well. The corners of our roof is like an L. So that is giving us more support to that particular area. So that support is also applicable from the junction of the palate towards that of the tooth or the teeth for say. Now that juncture between the palate and the teeth, when the major connector is following, should be not sharp and smooth as possible. Now that will give a more support and retention due to this L-beam effect. We'll come to that later. Now where is it indicated? But these are only indicated in the single posterior bar in interim partial dentures. It is not for all the partial dentures, because one of the most efficient disadvantage of this kind of posterior palatal bar is that the patient is not very comfortable with these kind of major connector. So it should never be used in a dental prosthesis or a situation where there is totally denturousness. Or it should be used, we can say it can be used with anterior teeth requires minimal support or requires a minimal area of replacement. Coming to the next one, there is a palatal strap. Now, what is palatal strap? Now, you can see a large area is being covered with these kind of major connector, and we can also appreciate that it has been in 3 different planes. Now, that 3 different planes is also gonna give, that is the palatal vault of the palate, the vertical and the lateral slopes of the palate, and the sagittal or the anterior slope of the palate. Now it is offering a great resistance to the bending or twisting forces. So that is how the beam effect works, and the greater the rigidity, more will be the bulk in the material, but less bulk is required for a major connector to sustain because of the gravity which it can pull it down. So we need to keep it as light as possible, and also we need to also see that it should be comfortable and not interfering with any occlusion or tongue action, basically, because the tongue has a habit of getting into the palate, so we are supposed to take care that it is not interfering with that. The disadvantage is that the patient can have like the full palatal coverage, so sensitivity or the taste sensations can be reduced in such cases. And also the patient can also have a gag problem because we are covering the palate. So sometimes if it is overextended behind the the posterior palatal seal area, it can cause gag to the patient as well. And also it has an adverse effect on soft tissue. If it is very tightly adhered to the soft tissue over there, it is gonna get problem and can cause papillary hyperplasia. Coming to the next one, there is an anterior-posterior or double palatal bar. Now, this double palatal bar is the greatest asset to all the bars that we have, because what is happening is that it has got excellent rigidity. Because of and that is a connector should not be used unless the remaining teeth has been in good periodontal support. That is one thing which we should be always keeping in mind. The evaluation of the teeth with the periodontal support is very important to provide anterior-posterior or double palatal bar. Now, what can be the disadvantage? If it has so many advantages of rigidity, also comparing with the soft tissue, that it has a very less coverage, it is not covering the entire palate, the patient is not uncomfortable, and also, it is the consideration that we are not giving burden to all the abutment teeth, all the pressures of the occlusal forces are just transferred directly to the abutment teeth, so the soft tissue and the bone beneath is not getting hurt so much. So what disadvantage do it has? The disadvantage is that it is very limited palatal coverage, so tissue contact is limited. So little support is delivered to that of the bony palate. But we know that palate is a primary stress bearing area. So it is not taking up entire load onto the primary stress bearing area, rather it is giving onto the abutment teeth. So the teeth can in a longer run get affected by its periodontal support, or by its the caries activity can start because of the more pressure, and cervical caries can get into the place. So it is also little uncomfortable to the patient in a long run to say. So that can be little disadvantage with it, but this is one of the best major connector that we can give to any patient. Coming to the next one is a horseshoe shaped or U-shaped connector. Now what happens in this is that we have a thin band of metal which is covering, running along the lingual surface or the palatal surfaces of the posterior teeth and extending onto the palatal tissues. We can see the palatal tissues are being covered, but it has to be, as I told you, as always, 6 to 8 mm away from that of the pharyngeal margin. Now how is that extended onto the palate and also covering to the rugae? It is not following our major connector requirement. But then the advantage with these kind of connector is that when there is several anterior teeth loss, this is the best connector that you can be using, because that the strong connection that it is giving can be the only vertical forces or the support, vertical support that we can say that has got with indirect retention directly with the major connector itself. So it is serving as a both major connector as well as indirect retention for the anterior tooth loss or class 4 kind of edentulous. But what comes as a disadvantage? when the vertical force is applied to either or both the ends of the horseshoe major connector, like we'll see in this picture, so what is happening? There's a tendency of the connector to spread or strengthen. So when it will start straightening itself, so what will happen? There will be poor choice of dental extensions into that of the stabilization factor. Number one, and number two will be the major connector will start losing its retention, of course, and also it has got very less resistance to any kind of flexing movement that can occur at the open ends of these major connector, because it starts straightening itself. So what will happen? The flexing force will be developing. So when flex will happen, it will start losing its retention as normally. Coming to the next one, that is a closed horseshoe shape or an anterior-posterior palatal strap. Now structurally it seems like very strong. You can see the structure is very strong in these cases, and also that it can be used in most of the maxillary partial dentures. The reason is we are not covering the entire palate. Number one, if there is a tori, these are the best ones to use for the anterior replacement as well as some posterior replacement. That is class 4 with some modifications, we can use this. Also, we can have not class 4 with some modification, this is like class 3 with some modification we have, but the anterior replacements are there because class 4 do not have any modification. So that is the rules of applicates, right? So advantage of these is the closed horseshoe shape is rigid connector, that the device is good support from the palate, even though have an opposing powerful in the palate. That is, we have the opposing into the, we are not imposing the entire palate, but we are subtraining or getting all the forces that is directed to the palate onto the major connector. So what is the disadvantage? Now again, there is a metal over the rugae area. So what happens with these? There is a phonetic problem which can develop. Any major connector which is on the rugae area will give you two problems. One is the phonetics, because rugae plays a very important role in our phonetics. Second is the taste sensations, and third is uncomfortable to the tongue. That is the length of the tongue for the, it contacts with the anteriorly and gives us some sounds like phonation. So those sounds will also get affected, number one, and discomfort at the end of the day. It gives some annoyance to the patient at times. So that is one disadvantage with these kind of. So like simply complete palatal coverage, even that is the same thing, though it has got ultimate rigidity and support in the cases, and we have this complete palatal coverage. The advantages is getting the maximum rigidity because it is utilizing the entire primary stress bearing area like we do in complete denture cases. Why do not we leave a complete denture, palate free? We completely cover the palate. The reason is the most important stress bearing area, that is the palate itself. So for those cases, it is where the anterior teeth replacement, we can use these kind of complete palatal coverage, because you do not have to have more of support from any other tooth or something. The palate itself is giving you the support. But what happens is extensive tissue coverage is there, so it can cause papillary hyperplasia. It can cause difficulty in phonation, taste sensations get altered, metallic taste comes into picture at times, and also oral hygiene maintenance in these cases is also one of the difficult and a major issue which concerns us. These were the all types of maxillary major connector. Let's come up to the mandibular major connectors. The different mandibular major connectors are lingual bar, lingual plate, we have double lingual bar or Kennedy's bar, it's also oftenly and most commonly known as, and also a labial bar. So the first one will be the lingual bar. So lingual bar, as we all can understand by its name, a bar which runs in the lingual area of the mandibular mandibular teeth. So now where are we supposed to use this lingual bar? Now it is very simple in its design. We can see it's very simple in the design. So where all we can use? You can use in all tooth supported, not tooth tissue supported, but yes, tooth supported. All the removable partial dentures can be given a lingual bar. Now with that, one more advantage of lingual bar is that when it is having, there is a space between the tooth, free gingival margin and that of the lingual bars, so the attachment of the food with the teeth and resulting in decalcification because of the food debris accumulation and all is not into picture. So that is one of the greatest or major advantage with these kind of lingual bar. Now the problem occurs is when your technician or the person who is going to fabricate this particular lingual bar is not efficiently trained. So what happens is, since to reduce, if you do not have the length of the sulcus deep, So once you are preparing the lingual bar and the person has prepared it thin, so what happens? It starts flexing. The rigidity comes into question over here and it breaks off simply. So that's the biggest disadvantage with the lingual bar. Otherwise it can be used everywhere with added advantage that it doesn't cause decalcification of the teeth as well. Coming to the next one, there is lingual plate. Lingual bar cannot be used in those cases where there is not insufficient space between the tissues in the posterior area. That is the edentulous area. There is no space in the posterior section. So those cases we cannot be using lingual bar again. So coming to lingual, there is lingual bar again. Now coming to the lingual plate, that is what is a lingual plate per se. So now lingual plate is also known as a periodontal support, or you can say periodontal splint in way of prosthodontists. That is because in those cases who are whose teeth are periodontally compromised, what happens is there is the probing depth increases, there is space between interproximal area, and also the teeth is not supported well by the bone beneath. So in those cases what you do is you can go ahead with the lingual plate. That is, lingual plate does what? It gives a total support, as we can see, to the teeth. Now this design which is shown here is with a lingual plate. It is a slip back design. That is a split back. That is where you are coming it down and again going up. So it is stepping back and again going up, stepping back and going up. Indicated in the cases where the patient do not want to close the spacing between their teeth. So those cases there we use the step back technique or step back kind of design in a lingual plate. Now lingual plate is basically which is covering the tooth. Now decalcification is the biggest question here. Yes, that is an added disadvantage with these kind of major connector. Another thing with this lingual bar, lingual plate is that yes, it can be used in a class 1 or class 2 edentulous caries situations. But yes, one problem with that is it is not giving any space for the oral hygiene maintenance. Also, it can interfere with the tongue at times. Yes, it is only indicated also in those cases where the sulcus depth is less. So half pear shaped it is actually in the structure if we see. So it is into less of oral hygiene maintenance. The patient should be well motivated before using a lingual plate, because first major thing is that it is periodontally compromised. Same thing is with double lingual bar. Even that is used for those cases where there is periodontal compromisation and there is posterior edentulous area. But yes, in this one added advantage is that it is not covering the entire palate. So it has got a little gap in between. So the oral hygiene maintenance is good. Also, it also interferes with the tongue. So that is another disadvantage with these kind of situation. But it has got adequate support in the posterior ends with the teeth, and also to the horizontal direction. We can see there is enough support to give to those cases to the who are periodontally compromised. Now, the problem again we have to keep in mind for lingual plate as well as double lingual bar is interference with occlusion, because what happens, we are closing the interproximal gap which is there in those cases with these kind of minor connector in that particular area. So now when we are giving these kind of thing, we have to see for the occlusion that it is not hampering with the occlusion. So these are the things that we need to take care about double lingual bar or Kennedy's bar. In this Kennedy's bar, what is happening is basically it is a lingual plate plus lingual bar. So that is the reason. And if the same thing happens from the labial side, if we have a teeth where we are covering it from the labial side. Now, why will we cover from labial side? Unless there is no sulcular depth present. In those cases, we have to go for labial bar kind of. In that, nothing will happen. This is all in lingual side. That will all be in the labial side. Also, in some cases of maxfect cases, that is maxillofacial cases, where the patient has lost his tongue or the floor of the mouth is being operated, so we cannot afford to give pressure onto the lingual side. So in those cases, well, we make a labial bar for those patients. One is that it is visible. That's one of the biggest disadvantage. Metal display will always be there. Coming to the next is the minor connectors. Now, what are minor connectors? Minor connectors are those components that is joining the major connector to any other component like indirect retainer or the denture base or the major connector or the rest, whatever it is connecting to, those are called the minor connector. Like it's a small brother of the major connector. So it's a minor connector connecting the minor things with the major connector. That is called minor connector. So now the need for rigidity is emphasized by its function, and it is a minor connector. The major connector can flex, that stress cannot be distributed if it flexes off. So that is one thing which we need to take care of. So what are the different types of minor connectors that we have? One more thing is that the minor connector, it also distributes the forces on the edentulous ridge to the ridge and the remaining teeth as well. So the occlusion forces on the minor connector that attaches to the denture base to that of the major connector passes to the ridge, or the attachment of the clasp, or the attachment of the rest, or the indirect retainer, whatever we give. Now this broad distribution of force which we are doing, it also prevents for any one teeth to get damaged or bearing all the destructive amount of force. It is distributing all the way. So that's one of the major use, or we can say the function of the minor connector. Now what are the different kind of minor connector it can be? One minor connector that joins the clasp assembly, that is a direct retainer, to that of major connector. Second, one that joins the indirect retainer or the auxiliary rest, we can say, in other words, to that of the major connector. One which joins the denture base to that of the major connector. And finally, which itself, it acts as an approach arm in case of RPI system. That is, we'll come through that. There is a rest. We have proximal box, and we have rest. We have RPI system, that is rest, proximal plate, and I bar. In those cases, it is acting as an approach arm, and that itself is acting as a minor connector in the entire assembly of the clasp. Now coming to the first one, that is, it joins the clasp assembly to that of the major connector. Now the basic advantage or the basic requirement for a minor connector is to be rigid, because it supports the active components of the partial denture and the retentive clasp. Now they also are supporting the prosthesis, that is preventing the vertical motion, vertical movement towards that of the rest. So they must have the sufficient bulk to ensure rigidity, and also sufficient amount of teeth should be covered so that one teeth is not getting the detrimental amount of force that is falling onto the partial denture. Coming to the next one is, which is joining the indirect retainers or auxiliary rest to that of the major connector. Now this generally rise from the major connector itself, yes, but they should be always in a right angle. That is important thing over here with the major connector, because and also if it is in right angle, that is fine, but it should not have any sharp angles. But the junction should be very gently curved rather than any sharp angulation. It should be designed to lie in that embrasure only between the tooth to dispose the bulk as much as possible, so that the forces that are acting will not tend to bend or break the minor connector in that region. The next comes is which joins the denture base to that of major connector. Now that joins the denture base to that of major connector. Now this may be of different designs that we will come across right now. We have different designs for that. Now we have, this is called the meshwork type of minor connector. We have lattice type. We do also have certain, we have a major connector as a mesh type and a lattice type. Also bead kind of thing is available. Now how is this formed? Now these are forming based on the fabrication when we are doing with the wax pattern. Now when it is like a meshwork kind, we are giving, we can see so many spaces in between the minor connectors. Whereas if you are coming to those of the lattice type like this, here we have large spaces kept in between one to the next minor, the parts of the minor connector in that. So again, now it has to have some advantages of all. Now this is one which we use maximum time, that is a lattice type, because it is giving enough space, number one. Also because here the denture teeth is going to come. So we need to have enough space so that teeth gets attached to that of the acrylic, that is a denture base present over there. So that space should not be hampered when you are using a mesh type. So entire area is covered. Now if you have to place a teeth, we have only less area present. Whereas in lattice type, you can place the teeth in between as well, keeping in mind after the denture base is being formed over this. So of course that is the trial part. So this is one advantage with these. Third is the bead type. And what we do in bead type and how will we fabricate that? In bead type, what we do is 250 nm of salt we sprinkle, or with the sugar we sprinkle during the casting procedure itself, onto the wax pattern that we have made. Now once that comes out, it comes out like beads all over. So that is how a bead type is formed, but that gives excellent retention because it has got too much irregular surfaces because of the bead. So it goes into the denture base, and the retention with the denture base to the minor connector or entire removable partial denture is very nice in those kind of cases. Coming to serves, which is the indirect retainer, which serves as an approach arm for the vertical joint projection or the bark type of clasp which I was talking about. We know that this Y type of clasp, that is a direct retainer Y type of clasp. Now in these Y type of clasp, what is happening is that it approaches from down. Now the major thing with these kind of clasp is it cannot be used where there is a soft tissue undercut present. Now when the soft tissue undercut is not present and we have decided to go for these kind of clasp, this clasp itself is, or this kind of direct retainer is also forming a kind of minor connector. The down part of the approach arm, that is, we can see that is acting as a minor connector in these cases. Now also one more thing is, from where it is connecting to the major connector, the area again that should not be sharp angles and it should be curved gently in cases. Coming to the next component, that is rest and rest seats. So now the rest and the rest seats. Now the rest seat is a place where the rest is going to come and sit. So where is the rest seat? The rest seat is going to be on the abutment teeth or the tooth on which the rest is going to come, and rest is a component of removable partial denture that we are going to fabricate. So two different things. Rest seat is a part of the tooth and rest is the part of the component of the removable partial denture. So now let's see. Now that is that component of removable partial denture that serves primarily to transfer the occlusal load or forces against the prosthesis down to the long axis of the teeth, and it is called the rest. And the rest seat is the prepared surface of the tooth or the fixed restoration into which the rest is going to sit. Now coming to the major, what is the advantage and how the rest should be given. Now the first thing is the rest, what are the function it is doing? The first function that it is doing is it is providing a part of the removable partial denture which will not allow that cast partial denture to give force onto the tissues beneath, because rest is going to stop it over there in that area, so the partial denture cannot go more down. So that is how it is preventing the vertical dislodgement of the denture and putting a detrimental effect on the soft tissues. First thing. Second thing is that this rest is transmitting the force to the long axis of the teeth directly to the apical area. So now what is happening with that? We have periodontal ligaments with the teeth, right? So those periodontal ligaments are going to take these forces, absorb these forces, and will not allow the forces to go onto the denture, or will not allow it to go onto the bone in that particular region. So the forces are safely transmitted, number one, and number two, it is not allowing the denture to dislodge from its position and go more downwards. That are the two advantages of the rest. Now what are the different types of rest that we can have? One is which is directly connected to that of the removable partial denture or the cast partial denture that we are fabricating. Now that type of rest is called a primary rest, the first thing. Second, we do also have a secondary type of rest or an auxiliary rest. Now what happens in the secondary type of rest and auxiliary rest? Those rest which acts as an indirect retention to that partial denture will be termed as auxiliary rest. It is different from a primary rest. A primary rest should be there. Auxiliary rest only then it can be named. That is a second rest onto the cast partial denture fabrication component that we are fabricating. Now, also important thing for us to justify is that these rests should be in the vertical direction. It should not be some inclined planes. What will happen if we keep it in an inclined plane? The forces will not go perpendicular to the long axis of the teeth. Number one. Number two is that if we keep it in a inclined plane, the food will go and get embedded in that particular area. So the cleanliness or oral hygiene maintenance becomes little difficult in those areas. These are the two important things that we need to consider for rest. And we can see here the rest which is there onto the... Now one more thing, it should be maximum on the proximo-incisal area or the proximo-occlusal area. So what will happen is it is not even interfering with the occlusion. So we have to keep it a little down the marginal ridge, and it should be like a saucer shape. It should not have any sharp line angles anywhere when you are preparing the rest seat. It should be like a saucer shape with half a length of that of the tooth and 1/3 as the width of the tooth. That should be the diameter how we keep it, and it should be more deepening from the center towards that of the marginal ridge area, so that it seats over there properly, and also it is giving a saucer shape. So what is happening? There is no sharp angle to forward the force directly into one area, rather it is distributing the force in that particular area. What are the different types of rest that we can have? We can have occlusal rest, because it is a name, it is seated on the occlusal area, so occlusal rest. Lingual or cingulum rest, that is seating onto the cingulum area of the anterior surfaces. Usually in the maxillary canines we give. Now these kind of rest which we are giving in the cingulum area, we should keep in mind again about this is that these kind of rest that when we are providing, it should not be placed onto the teeth which has a less surface area, like lower central incisors. We should not be placing over there because it cannot take up the force, number one. Number two, extra amount of tooth is we have to prepare that area for the rest seat preparation. So loss of too much tooth structure is affordable only where there is tooth structure present. So bigger teeth like canines we can use in those cases. Or we have some incisal seats for the anteriors, like seated on the incisal edges of the tooth, usually like in mandibular canines that we do. So the three forms of rest that I told you: occlusal rest, lingual or cingulum, and the incisal rests. So these are the examples of occlusal rest and rest seats, that it is that it is prepared that the occlusal surface of the teeth, when it is occluding, it should not be interfering with the occlusion. So checking of the high point even after providing occlusal rest is very important. And also the slope or the shape of the rest should be followed as clearly as possible as the outline of the teeth or the mesial or distal fossa of the occlusal surface of the teeth on which we are providing. And also the size of the rest seat that we are giving should not be as big enough to cover the entire area, because it can cause again decalcification of the teeth in that particular section. So it should be kept as less as possible, and tooth measured from cusp tip to cusp tip. When we see the width should be, buccolingual width should be maintained even in that case. It should be half of the buccolingual width and 1/3 to that of the mesiodistal width of a tooth. That is generally accepted. Coming to the lingual or cingulum rest. Now what happens in lingual or cingulum rest is it is used primarily on the maxillary canines that we can see, and also indicated for using a missing canine, used in as a missing canine. Now what happens in that is the lingual rest is nearer to the center of rotation of the supporting tooth. So it does not tend to tip the tooth. So that is one of the great advantage of cingulum rest. Addition to that, we also have that since the cingulum rest is confined to the lingual surface of the anterior teeth, it is more acceptable aesthetically because we cannot look into from the front region. And also the configuration of this lingual rest is such that the distortion or breakage or tipping forces can be avoided in these kind of rests. Similarly, the incisal rest or the rest seat incisal rest, that is we are giving generally onto the lower mandibular incisors as well as the canines at times, because but the only thing is it is less desirable because you can see that metal display from the front. Aesthetically it is very unsound to use a incisal rest or rest restoration. And one more thing is, in this cases when we are giving incisal rest, the abutment selection is very important because we are covering the entire tooth lingual surface and giving it on the incisor area. So now once we are doing this, the chances of, if the patient is not maintaining oral hygiene, decalcification of the teeth is very much common. So it is not indicated. So it is generally indicated on the incisor teeth, except under the unusual circumstances that comes up, like the excessive parafunctional habit with the patient, where they are designed to, the mesio-incisal or disto-incisal area of the teeth will have these kind of rest seats to take up the reason. But aesthetic reason, we do not use it generally. Coming to the direct retainers. Now, the different direct retainers, that is that component of that engages an abutment tooth and is so going to dislodge forces applied to the removable partial dentures, is called the direct retainer. Now, direct retainer, also known as clasp in local in our terms at times. Now, because direct retainer can be of two types, there is intracoronal and extracoronal, that is inside the tooth and outside the tooth structure. So these are the two different types of direct retainers that we can have. And also we do have, that will prevent the Now the abutment and the location of this kind of retention on an abutment teeth must be very carefully examined and controlled to prevent any damage to that particular supporting tooth structure. That is again very important. Intracoronal retainers, like those which are attached to the crown or inside the crown, as given by our Sir Dr. Herman Chase in 1906, is that is an internal attachment which is provided inside the crown. Now, because Dr. Cheese had given this, he said that the width of that crown should not be big enough again. It should not be so big to accommodate another unit into that. So the second unit is inserted into that removable partial denture. So it has got a male component and it has got a female component. So the male component that will be there into the crown or the removable partial denture, and the female component somewhere into the tooth structure that we are giving. Extracoronal retainers. Extracoronal retainers, those are from outside. Those are from outside, extracoronal, outside the crown area. So those can be further classified into circumferential clasp or vertical projecting clasp. That is circumferential, also known as Acker's clasp, or we have vertical projecting clasp, or also known as bar clasp or Roach's clasp. These are the different names given. Now, so Devan actually, clarified with these when he gave the term supra bulge and infra bulge. At that time, he came up with these kind of clasps that can be in the extracoronal as a retention. Coming to the circumferential or the Acker's clasp. Now, the circumferential or Acker's clasp. So, circumferential clasp or Acker's clasp, as we know very commonly, these are the terms which we use, or C clasp, very common term used, has two clasp arms. Now, one which is a retentive clasp arm and one which is a reciprocal clasp arm. Now, those two clasp arms are circling or encircling the abutment teeth. So that is the reason from outside, because it is encircling, it is called the extracoronal kind of clasp. Now, this clasp, with the exception of the retentive clasp terminal, that it goes below the height of the contour, but it approaches from the highest bulge, that is the supra bulge it comes from, and then enters to the undercut area. Whether it is a mesiobuccal undercut or distobuccal undercut, that depends on case to case, and that will matter which clasp design which we will be taking up. So now this is that is a difference also between the circumferential clasp and that of a vertical projecting clasp, is the way the retentive arm is coming. In the vertical projecting clasp, it comes from infrabulge area, whereas our suprabulge area, when it comes from, then that will be called as a circumferential clasp. Now, in the circumferential clasp, we also have something called as combination clasp. Now, combination clasp is that type of circumferential clasp which has a retentive arm of a wrought metal alloy. Now, wrought metal alloy, that is what we use in ortho. So what you do is you solder that after the preparation of the, after casting of the removable partial denture, you do it. Now, what happens and why do we do that? Because it makes it more flexible in its design, is similar construction of a cast alloy. The reciprocal arm, that it must be, it should have a counteract with the forces that is generated by a flexible wrought metal alloy in that area. Now, the retentive terminal reaches the undercut from above the height of the contour as those of all circumferential clasp. So, it is also considered under circumferential clasp. But due to its flexibility, it can be used in mesiobuccal cases where there is mesiobuccal undercut. Most common indication for a combination clasp. Coming to the next one is a vertical projection or a bar clasp or a Roach's clasp. Now, what happens in these is extension of the metal framework of the partial denture that protects along the mucosa, and it projects from the mucosa, crosses the gingival margin, free gingival margin, then it goes up to the height of the contour, but it remains below the height of the contour and in the infrabulge region of the tooth in the cervico-occlusal direction of the tooth. Coming to what are the components of a clasp assembly. Now, the clasp assembly that will have components called reciprocal arm. On the bracing side, we will have retentive arm. Retentive arm is further into three parts, where the first two sections of retentive arm is above the height of the contour, and only the retentive tip goes below the height of the contour into the undercut area. We do also have a body of the clasp arm. We also have a shoulder, like from where the retentive and the reciprocal arm is connected to that of the body. We also have a rest onto that of the clasp arm, like an embrasure and all. And in a vertical projecting, we have a minor connector connecting to the vertical projection body, we have a shoulder connecting to the reciprocal and retentive part of the vertical projecting arm. Now, what are the importance and what are the requirements we should have in these things is that it should have retention, it should give stability, a support, reciprocation, passivity and encirclement. We'll come to one by one of all these things. Retention, as we know, how are we going to give retention? So the retentive arm of the clasp assembly is going to provide us retention. So how is that providing? Because the retentive tip or the retentive arm's terminal end is going to go behind or beneath the height of contour, so that will go and engage the undercut area. So that will not allow the clasp assembly and the entire cast partial denture to come out, because it has a bulk, it has a beneath the bulk it is going. So it is only that particular portion of the retentive arm, that is the only the terminal end of the retentive arm, that is going beneath the height of the contour. Now, also we need to see the amount of retention that a clasp arm is providing. It depends on the flexibility of the clasp arm, of course, and the depth that the retentive terminal extends into the undercut area. As we can see here, the amount of clasp arm that extends below the height of the contour is going to dictate its retention. The support, as we all know, how is the support here? The property of the clasp that resists the displacement of the clasp in the gingival direction, as we have discussed in the complete denture support, stability and retention. The definition remains the same. The primary support from where we get is through the occlusal, lingual or the incisal rest that we are giving. Now the manner in which this rest is placed onto the teeth is going to dictate the support that particular cast partial denture is going to have with. But it will also, important to understand that the rest should not be provided onto the area where there is encroaching too much of the bulk of the tooth structure. So it should be in little area, saucer shaped, so that it will be acting as a vertical support to that particular cast partial denture. Coming to the question of stability. Now stability is a resistance to what? Horizontal displacement of the prosthesis. Now all the clasp components that except the retentive clasp terminate contributes to this factor of stability. All the factors like shoulder, body, your rest, your reciprocal arm, they all leads to stabilization of the particular cast partial denture. The wrought wire clasp, that is a combination clasp, has a flexible shoulder as well, and the bar clasp does not have a shoulder, or both it provide less stability. So that is the reason a cast partial denture of having combination clasp or a vertical projecting clasp, the stability is less because we do not have a shoulder to give more stability in those areas. All three clasps that have a rigid reciprocal or a bracing arm, which will provide equal amount of stability in a particular prosthesis. Coming to reciprocation, now this reciprocation factor is well understood in a cast partial circumferential clasp, because on one side we have retentive arm, on the other side we have a reciprocal arm. But how about a case of a vertical projecting arm? In those cases, how are we going to get this reciprocation? Now that reciprocation is provided by the proximal box that you're providing for a vertical projecting clasp or an RPI system. But it should be positioned onto the surface of the tooth that is, reasonably parallel to the denture tooth that we are giving. Now because it will also help in the one single path of insertion and removal of the prosthesis as well. Coming to the next property, that is encirclement. It says 360 degrees is the best encirclement. At least provide more than 180 degree of encirclement. That will also lead to more stability and support of the particular cast partial denture. So now if we give more of tooth encirclement, the disadvantage is again decalcification of the teeth can happen. So we are not supposed to even include that too much. So we have to keep it less, but a little more structure should be encircled so that we can have more stability with that of a cast circumferential arm, clasp arms, or broken contact with that of the bar clasp in those cases. Passivity is one more important thing. Any cast partial denture should not be actively seated, as that cases of the orthodontic loops that we are giving over there. That should not be like Adam's clasp or anything which should be actively set in some place, because an active placement of a cast partial denture every day is going to do a loss of the tooth structure. Number one, constant pressure on abutment teeth is going to be there. So that constant pressure on the abutment teeth can be detrimental to the health of the periodontium and the structures beneath the abutment teeth. So for coming to certain circumferential classes, simple circlet clasp, or that is a most versatile and widely used, that is a C clasp we say. It is most clasp of the choice for the tooth supported kind of partial denture, where the available resin tooth that we have undercut is permitted to use. That is the undercut next to that of the edentulous area is there. That is we have a distobuccal undercut almost, and it engages the undercut remote from the edentulous space. We can see from the edentulous space away it should be. In those cases we can use simple circlet clasp. Reverse circlet clasp is used where reverse circlet or reverse approach or circlet clasp that is used in cases where the retentive undercut is located on the surface of the abutment teeth adjacent to the edentulous space. So what happens, you have to go back and then the circle will come and go into the engage. Like in class 1 edentulous Kennedy's area, if we have a distobuccal undercut to engage, we will be using reverse clasp. Coming to multiple circlet clasp. Now multiple circlet clasp is essential to opposing simple circlet clasp, we can see, which is joined in the between or the terminal ends or the body. It is used primarily in the sharing the retention responsibility. If one teeth is not that great with their periodontal support, it is going to take the help of the other teeth. It is like sharing and caring for that particular one teeth, so distribute the forces in two. This may be considered a form of splinting the weakening teeth as well, because by a removal partial denture, we can also splint the teeth with the help of these kind of clasp. Coming to the embrasure clasp, maximum and mainly used in the case of class 3, where there is on the opposing side there is a missing and one side that all teeth is present. In those cases we can be using embrasure clasp, because it is a simple circular clasp joined in the body area. It is most frequently used in side of the arch where there is no edentulous space present. Of course, then only we can go for embrasure clasp. Coming to the ring clasp, we can see ring clasp, where is it indicated? In the tipped molars. Basically in the case of the tipped molars, we use ring clasp. Now the basic advantage of a ring clasp is its encirclement. The encirclement of a ring clasp is total 360-degree encirclement. So in those cases it is giving good stability, but only where there is a tipped molar. So you cannot be using a crown or a telescopic crown in those tipped molar cases. There we can go ahead with placing a ring clasp. The other kind of clasp that are also available are fish hook clasp or hairpin like of clasp. Those what are happening, it's like it goes and then comes down. So the one area which goes and comes like a hairpin, that is below the height of contour or the bulge area of the tooth. Now, and also important thing, those clasps will be used where the edentulous areas next is the undercut. The undercut present next to the edentulous area. In those cases we will be using hairpin clasp. We have onlay clasp as well, that is extended onto the occlusal rest with the buccal, and it has a lingual clasp arm. There is an onlay type of clasp. Now this is a bar or the vertical projecting clasp we can see in the end areas and the posterior. Case of a Kennedy's class 1 situation, bilateral edentulous posterior region, where we have and we do not have any soft tissue undercut as well. In those cases we can be using a bar clasp. One important thing to understand with a bar clasp is that the T or the I or the Y, whichever design that we are using, it should not be above the height of the contour, number one. Number two, the connection with the major connector or minor connector to that of the bar clasp, the approach arm basically, that should not be right in sharp angles. It should be like a gently curve onto that of the mucosa. So that has to have a half round circulation, half round configuration, because again it should be adhered to that of the mucosa, and if it is a full round configuration circle, then it will be like a rod, so it will not completely touch the particular mucosa over there. Food lodgement can again be taken place. So that has to be taken care of. And the greater the length of the clasp and more we have the tapering in those areas, the more will be the flexibility of the arm that we know. So what are the different types of bar clasp that we can have? We have T clasp, that is like a T we can see. We have I clasp or I bar, I clasp or an I bar, that also we have. Now I clasp is used where we can see I clasp on the right hand side, that is I clasp, where only one particular eye is just encroaching onto that, or occasionally used on the distobuccal surface of the maxillary canines for aesthetic reasons. And there is a definitive tapering and danger involved with this, that is using this kind of clasp, is that the dislodgement. And because the only contact of the retentive clasp with the abutment teeth is the tip of the clasp, the area of 2 to 3 mm encirclement is into the questionable part. So here the compromisation of stabilization factor of a clasp is always seen in these cases. Whereas this kind of eye bar is the most successful thing in RPI system, where we have a rest, proximal bar and eye bar given, where the change of the rest is now taken place. The rest is no more used on the distobuccal, it is mostly now used in the mesiobuccal. The reason is that when from mesiobuccal rest will be used, the tipping forces on the abutment teeth and the denture tipping will not occur, because you will have an indirect retainer to keep it down. The forces will not have detrimental effect on to that particular abutment teeth when the tipping of the denture or lifting of the denture is happening. Coming to indirect retainers. Now indirect retainers is that component we can see of the partial denture which is supported entirely by remaining all components and the natural teeth. Usually does not require an additional support than that of the which is featured by the primary abutment teeth. So then it is not like a primary support, it is like a secondary support. Now about indirect retainer, whenever we come across, now indirect retainer, why is it so important to give? Like we can see in this picture, when the forces are coming from the long axis of the teeth, if there is this rest on the distobuccal area of the tooth given, which we can see from the class, simple circlet class we have, and the distobuccal has a rest which is projecting. In those cases when the force will be on the abutment teeth, when the rotating force will happen, so the force is going to go on the abutment teeth and it is going to tip. If there would have been another rest to support that, so what will happen if even that wants to get up, it will not allow it to get up, it will allow it to go down. So that is like it is increasing the liver arm. Basically it is increasing our liver arm from the area of fulcrum away which it should be. So it is said that indirect retainer should be as away from the primary rest that is given. So how will we decide that? So take a line, imaginary line, which passes from one end of the distal rest to the other end of the distal rest, and make a perpendicular from the center of that particular line wherever that line will pass from. I repeat, from the distal ends of both the clasp rests, make a imaginary line. Mark the center of the line from the distal rests and then project a perpendicular line. So wherever that line is going to fall on, we will give our indirect retainer in that. So basically in a situation of a class 1, we will have 2 indirect retainers responsible, whereas a class 2 can have only 1. So that will again depend on the cases that we are doing, and it should be as far as possible. Like we can see in this, we have 1, 2, 3, 2 indirect retainers, and rest we have our primary rest. So indirect retainer is a form of a rest only. So it is going to come and rest on the abutment teeth other than the abutment teeth, so that the denture, when it is getting up, it is not allowed to put any force on the abutment teeth, or abutment teeth is saved. So these are the type of indirect retainers. So what happens is the movement towards the supporting ridge will be limited by the supporting ridge and will be equal to the amount of compression of the mucosa and or the amount of bone resorption that is happening, that has taken place already since the partial denture has been constructed. So the vertical component of this particular rotating motion towards that of the ridge can be controlled only by stable denture based support, and indirect retainer does not control any movement, but it just controls the way the forces are distributed. Coming to the next is denture bases. Now denture bases, plastic or acrylic metal denture base can be used. Those areas which has metal, that should be very clean, and which should have all the areas absolutely shiny, so that there is no food particles coming, no candida coming in that particular area, so that later on fungal infections are stopped and it can help not to happen. Also, denture bases that we are supposed to use should have, earlier when we are fabricating, we should be using some spacer to give space to that denture base material that we are supposed to use, because it should be adhering to the the tissues beneath it. So the denture base is that is how there. Number one. Number two is, before fabricating a removable partial denture, to understand the thickness of the denture base, we need to calculate the inter-arch distance. Now that is another important thing. But if we use a metal denture base, for say example, we are using a metal denture base. What happens, particularly in distal extension cases, what will happen is that we cannot reline the denture base. In case of an acrylic denture base, if it gets loosened up, if it is not fitting properly, we can always have, we can reline it. But if a metal denture base is planned for a partial denture, extreme care must be taken, to make that procedure, because overextension of the denture base borders must be avoided, because its metal is going to be sharply, hitting to the particular this one. If we have tori, we cannot be using again the metal denture bases, and large amount of partial denture distribution of the teeth forces are required. But if we are using an acrylic denture base or acrylic resin, the use of a characterized acrylic resin is to duplicate the soft tissue tones of each individual patient, can permit the placement aesthetically as well, because metal will be like metal, but then when we are using an acrylic, it can have little color of the mucosa. That is one of the greatest advantage of acrylic denture based resin, is that the artificial teeth is also of acrylic, so it gets very nicely positioned exactly where the original teeth were, regardless of the loss of the ridge or whatever may have occurred. The restoration part becomes easy when you are using acrylic resin beneath it. In selected cases, the resin of the denture base, may be like more of a base may be used as for the resin denture base for the normal contours of the lip and the cheeks as well. So care must be taken in that instances not to oversize the abutment teeth, not to overstress out onto the abutment teeth. What are the different options for replacement of the teeth? Now the basic and important thing is the acrylic teeth, or the major acrylic teeth on the removable partial denture position on the denture base. Now however, it is said that the teeth should come the place where the teeth was there earlier. But think of a situation where there is long time edentullousness. So the teeth in those areas must have drifted. The supra-eruption of teeth must have happened. So we need to take care of all those things and then go ahead with the combined thinking of inter-arch distance, the occlusion, and then placement of the denture base, and then on that will be the acrylic teeth, which will act as a pontic itself. So we also have some other different types of acrylic. We have some, say, anterior tooth replacements that is done here, anterior teeth which can be replaced, that is with the removable partial denture. We have a gingival contour given with acrylic denture. It can also be done with silicone. These days we do it with silicone. And we do also have wrap, that is resin reinforced acrylic pontics. We have tube teeth techniques. These are different, these are the methods that we can use. Facings we can use tube teeth, we can use reinforced acrylic pontics. So the characteristic of all the teeth of these which we are using replacements can be thought of, like denture based teeth on the denture base, acrylic teeth used on the acrylic denture base is the best one to, as an aesthetics as well. Also in case of retention, this is a very good, because it restores the portion of edentulous ridge as well. Limitation is difficult to use for a single tooth replacement. It is very difficult. And also the bulk, due to the bulk, the strength gets, very compromised in these cases. If we talk about the facings, if I am only talking about the facings, then what is happening is, the advantage is that in those cases, a single tooth replacement very nicely where interocclusal distance is present, of course, but interocclusal distance is very less in those cases. Also, we can be using facings. Also, the strength is required in those cases. The facing can give you more strength. Whereas the limitation or the disadvantage of facing kind of restoration is that it is difficult to obtain a good aesthetic result with these kind of facing, because already we have a metal display somewhere on the posterior side or the lingual side. And one more thing, it cannot be relined. That is another disadvantage. And later on, when there is a question of relining, this becomes a little difficult. And opposing occlusion is gonna come against the metal surface. So what is happening is abrasion of those occlusion natural teeth is going to take place. And also it cannot be used in a resorb case, because too much of forces are given onto the resorb ridges. So we cannot be using that. Coming to the tube teeth, like we can see where is the name and the picture suggests, like it's a tube is coming, and onto that we will have our teeth present. Now what is good about it is it is giving good aesthetic replacement of a single tooth because it shows that it is coming from inside where there is space available. But opposing teeth will occlude against that of the acrylic only, or the teeth itself are not onto that of the metal. So that's like another advantage, but it has to have some limitation. The limitation is that it must have ample space mesiodistally and buccolingually to put these kind of tube teeth. And it requires a well-healed, non-resorbed, non-resorbing surface, or a ridge that is resorption, because resorption is very important factor here. Resorption happens very rapidly. Already if some ridge is resorbing, we cannot and should not be using in those cases. It also makes an excellent single tooth replacement, particularly in the premolar areas we can use this. That's most indicated for these kind of teeth. Coming to wraps or reinforced acrylic pontics, what happens? Excellent sound, aesthetics and strength is there. It can be designed so that the occlusion is confined to that plastic, and it can be used in restricted space as well. That's the advantage of this. Whereas the disadvantage, again the same, cannot be relined, resorption area cannot be used, and little support is gained from the ridge. So the portion for those areas are not indicated for retention. Porcelain teeth, only when should we use porcelain teeth? When the acrylic artificial teeth are opposed by an artificial teeth. That is, we have a porcelain teeth on the other occlusion end. Only those cases you are supposed to use porcelain teeth. Why is that so? Because of the abrasion. It can abrade out the natural teeth, or it can abrade out the acrylic teeth if it is there on the opposing side. So it should be only used if both the sides you are using porcelain teeth. It's a well, because the forces, the chewing efficiency of a porcelain teeth is the best. So the patient do not feel like he has got some artificial, because as a resin teeth, the chewing efficiency is not that great. The mastication is not that comfortable, and grindness is not that comfortable. In a porcelain teeth, grindness is comfortable, but what if that has got natural teeth? It is going to abrade it all totally. So in those cases, we are not supposed to use porcelain teeth again. Coming to metal pontics are indicated again when opposing there is a metal pontic already present. Otherwise, we are not supposed to use metal pontics. Also, we can use metal pontics in opposing occlusion if they have a natural teeth. There is no issue about it. So these are the different components of removable partial dentures where we are supposed to use, plan out, see what case we have. Remember our fabrication and framework design techniques, and the framework design principles that we had spoken about, the broad stress distribution and physiologic basing, and based on all those factors and the edentulosum and the tooth evaluation, we will decide on to which major connector, which minor connector, where the rest should come, where the primary, where the auxiliary rest, where the indirect retention should be provided in the particular teeth. And of course, at the end of the day, denture base, how it should be, and what kind of artificial teeth that you're going to put to replace the missing teeth. Thank you.